Addressing workplace violence is our episode topic. My guest, Bill Schueler, is a registered nurse with a board certification in emergency nursing, a certified professional in patient safety, a certified workplace violence and threat specialist, and a fellow in the Academy of Emergency Nursing. Bill co-authored Chapter 26 in Strauss and Mayer's second edition of Emergency Department Management. The chapter's title is Violence in the Emergency Department. Bill has also authored chapters in Sheehy's Emergency Nursing, Principle and Practice, 7th edition, and the upcoming 8th edition of Sheehy's Manual of Emergency Care. Bill has presented on workplace violence at multiple national conferences, including ENA's annual conference, as well as NTI. Bill is active in workplace violence public policy initiatives in Oregon as well as at national levels. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Bill, thank you so much for joining me today.
Thanks for having me.
Yeah, the Joint Commission has come out with some new regulations or standards around workplace violence. Can you talk a little bit more about those?
Sure. So the new standards that went into effect in 2022 try to address a few things. Is now you have to have a violence prevention program. You have to collect data. You have to do your surveys. You have to respond based on those surveys. You have to have a dedicated person that leads your program. So like an executive sponsor per se. And they also want you to report it up to your board. So those are some of just a handful of the new requirements that the Joint Commission put forward in early 2022. But hospitals were notified June of 2021, knowing that this would go live and understanding that as soon as they started their survey year in 2022, there's still going to be some ramp up of how the Joint Commission surveys hospitals, specifically to workplace violence.
A lot of that sounds more on the reporting side, which clearly 10 years ago was a huge issue with the taboo of no one reporting anything. What regulations or standards exist around actually taking care of staff after these events occur and mitigating them from never happening in the first place?
From a public policy perspective, there's nothing nationwide yet of a requirement to aid violence or educate or care for injured caregivers after. I think generally it falls under the OSHA general duty clause still. And we know from multiple publications that at least the publishers or the writers feel that OSHA is not keeping up their end of the bargain. It's essentially the law says you have to keep your employees safe from known hazards. And workplace violence is a known hazard. And in fact, OSHA calls it they highlight it. And it's a high risk known issue. OSHA is that way. Oregon, where I'm from, Oregon OSHA has its own publications on workplace violence, especially in healthcare. But when you get to mitigation factors, I think we're up to 13 or 14 states now have specific laws on their books regarding violence prevention in healthcare and providing education programs, even to the point of a little prescriptive of what's in your education program, addressing self-defense, to keeping reports. As far as reporting, like here in Oregon, we're required to keep an assault log, but we're not mandated to report it to the state. California does have mandatory reporting. If there's a significant injury, I believe you have to report to the state. It's either 24 or 72 hours. But as far as getting back to the mitigation or caring for caregivers, I'm not aware of anything that mandates that you must do certain things after a workplace violence incident resulting in injury. aside from your standard OSHA required
Okay.
elements.
And so, separately from those standards, we've got two professional organizations, AONL, the American Organization for Nursing Leadership, and then ENA, the Emergency Nurses Association, that has guiding principles that are put together around mitigating violence in the workplace. Are there any pearls of wisdom or key things, tenets that you think that we need to pull about out of that and talk about?
Yeah, I think, like you mentioned earlier, I think reporting still remains an issue. I think I report, nothing happens, nothing changes. So why bother reporting? I still think that exists. And that's been in the literature for a long time. Having a plan. What stands out to me is we can't say it doesn't happen here anymore. It happens a lot. And if the data shows that healthcare workers are 5 times more likely to be assaulted at work than any other type of business, that's concerning. And if healthcare workers suffer over 70% of injuries requiring days away from work, from workplace violence, over 70%, those are alarming statistics. And we take care of people in healthcare. The risk for violence is always there. And I think we're just starting to shine the light on the actual problem. So the guiding principles are very good. Just in general, if you wanted to be more specific, I would recommend a violence prevention toolkit that shows you, because I think the guiding principles of, okay, here's the big topics that you should probably address, but a toolkit can say, here's the different problems that you probably should look at, and here's how to go about it. And here's how to collect data. Here's maybe what you should educate and how you should educate, how often, to what type of reporting are you collecting? What type of data are you tracking? I think it's time to get granular and really dig into the deep end, or dive into the deep end for violence prevention and really put the resources. It's one thing to have guiding principles. It's actually another thing to actually do them.
Okay. So let's talk about practical solutions. This is what you do in your line of work as a patient safety specialist. If I'm a nurse executive in a hospital or a health system right now, we know that it's happening in every hospital across the country. What should be my first 3 to 5 things that I need to look at to make it a safer place to work?
So 3 things. The first one I would say is have a plan. Really to have a plan to mitigate, to prevent ideally, but knowing that we can't prevent all workplace violence. But then on the back end, I think, which is probably even more essential, is to have a plan of how do you respond to an incident, after an incident, and how do you support the caregiver or care for the caregiver after the incident. I think that's the more important part of your plan. And your plan can start with comprehensive policy that addresses what to do before an incident, maybe address what happens during an incident, but also more importantly addresses what to do after, who does what. You can be fairly prescriptive in there. What's your education plan? What's your follow-up plan? What's your committee structure? Things of that nature can be placed in your policy. But also part of your plan is committees. The Joint Commission does require a multidisciplinary committee that helps with violence prevention. And you might have, like, I work for a health system. I work in a region that has 8 hospitals. We have a regional violence prevention committee. We have a regional core team or a steering committee. But then each hospital has its own workplace violence prevention committee. And they all operate differently. They all have different structures and different memberships, but we try to standardize as best we can. So committee structure can help with your plan. I think a strong executive sponsor is critical because you might need some funds for what you want to do with violence prevention, some initiatives. Like, for instance, some of the hospitals around us are taking all at once. They're taking some actions. And if you want to buy a metal detector for your emergency department entrance, that's going to cost money. What's even more concerning, from what I know, is that it's the staffing of the metal detector that seems to be the biggest issue and the biggest cost. It's not the cost of the metal detector. Those are actually fairly reasonable in their cost. It's staffing. Do you have enough of your own staff to staff it 24/7? Or do you have to hire out and contract security folks to manage your metal detector? To canines, bringing in canines in your unit or into your hospital to help with de-escalation and help reduce crime that might happen on your hospital property, to robots that can help patrol your property so that it frees up your security staff to stay in the hospital and address the concerns that are within the hospital. Knowing that from what I've been able to see, really the robots are there to observe and report. And a security professional can watch the camera. They can talk through the robot if there's anything concerning. But that's another thing we've seen. Those are the major things we've seen as of late is canines. Another one it can be somewhat controversial is body-worn cameras for security staff.
How does that work within the auspices of HIPAA and patient privacy?
Yeah, it's if everything's internal, you should be okay. Another argument for that is like a lot of hospitals have security cameras already observing areas. Maybe they don't record sound, but there's one local hospital that has instituted the body worn cameras and they went through legal and it was approved. But the officer also has to say, we're on camera. So he has to notify not only staff, people who they're interacting with, that there's camera recording. And you really do base some of it off of what already exists in law enforcement. For law enforcement, since they're a public agency, if somebody wants to watch a body worn camera video, they have to produce it. But they also have to protect the identities of people who aren't involved. I think not an expert on body worn cameras and the legalities of it, but same thing wouldn't be just generally released. It's probably stored for only a certain amount of time before it's automatically deleted unless you save it for certain incidents. But people find it as a good accountability tool, both for the people that they're interacting with, but also the security staff as well.
So let's talk a little bit about, you mentioned metal detectors earlier, and just thinking about the EDs that I've been in, metal detectors, provided they're adequately staffed, can ensure security at that one point of entry. But if you're not looking at the access control overall to your department or to the facility, that metal detector is an N of 1 in 100 access points. So
Correct.
what else needs to be looked at then on an access control perspective when we're talking about metal detectors?
Yeah, I think you raise a good point of if you're only going to have a metal detector at the ED entrance, you're not capturing probably a lot or most of the traffic that's coming through your hospital. So there's been, from what the literature says, is ideally you might have metal detectors at maybe a couple entrances, but you funnel everybody, visitors, staff, you funnel them all through one place so they all get screened.
Including staff. You're saying
in-
staff should also get
Some studies have said including staff. If you want it to be top to bottom, trying to look for weaponry that you don't want in your hospital or devices you don't want in your hospital, you would screen ideally everybody and you would funnel everybody to just one or two entrances into the hospital. But access control is a safety issue. I think of one of the ERs I worked in not too long ago. And so you could come into the emergency and you see the triage booths and you see the registration desk, but you just walk over a few feet and you turn to your right and there's two open doors. And it's what I call an infinity hallway. It just goes for a long time.
Yeah.
And anybody could walk in there and they'd have access to the entire hospital. Typically, I think most emergency departments have locked access to the main area and things of that nature. But do your triage doors have locks on them if you need them? Full routes of being able to escape versus just one door, things of that nature. Metal detectors don't come without their own risks as well. As if you're going to have people queuing in a line, so they're waiting to be screened and there's somebody with a medical emergency that you don't catch, and maybe that wait is detrimental to their health. You can run into some issues with that. Okay, so let's say you find some weaponry. What do you do with those? Even was able to look at a list of concerns or learnings. It's those machines produce heat. Do you have enough air ventilation? How much space do you need to allow people to move around or even get a wheelchair through? The other concern, not only just for just a stationary metal detector, but what do you do with patients that come in via helicopter or ambulance? Some of those likely could have weaponry on them, and some of them I've heard stories of a trauma patient comes in, they go to CT and they find that there's a gun in their back waistband that you see on CT. Some places will recommend of all those patients. And then the other factor is who does the wanding. Do you have enough security to do that for everybody? Or are you going to start relying on your clinical staff to do that? And I think that's where clinical staff gets uncomfortable is it produces a weapon that shouldn't be here. What do I do with it? How do I interact with it? And clinical staff probably are not the most trained people to address that, where security staff probably are.
So, inspecting the posterior surface is part of the secondary survey. I'm wondering how they got to CT before and didn't determine that while
Yeah.
inspecting the posterior surface on their secondary survey. But interesting point. Good thing they were in a CT scanner and not an MRI machine.
Yes.
What are your thoughts around education for staff? There's people that are doing a variety of different training programs that are out there right now. Is there one that's more effective than the other? How often should staff be getting that education and training? How do we make sure that we keep those things at the forefront of our mind?
Yeah, that's a great question. From what I know from the literature, it's up in the air whether education is an effective violence prevention strategy. Now, that being said, I wouldn't dismiss it all. I would say it is an essential part of your violence prevention program. Now, there's many commercial violence prevention programs out there. You got the Crisis Prevention Institute, CPI as it's commonly known. You have MOAB, which is the management of aggressive behavior. You have Evade, and there's multiple small ones that are not as well widely known out there. They all differ. I think the core tenets are the same, but they might have a different philosophy or a different theory behind what they do. Some might be more influenced by law enforcement or military versus healthcare, but they all vary. And I don't know of a study that has looked at the efficacy of these just because there's so many different elements and how are you going to measure outcomes? That study hasn't been done yet. I had a talk with Professor Gordon Gillespie or Dr. Gillespie and years ago, because as I was starting my violence prevention journey, I was in a research session at one of our ENA conferences, and I'm like, I have these ideas about a study I want to do. I have all these questions. I'm reading about this author, Gordon Gillespie, and he just happened to be in the room. And he's, that's me. I'm like, awesome. But he highlighted to me years ago the struggle with being able to study violence prevention in healthcare. Because are you going to have a control group that doesn't have any training or anything and then do the control? You have to look at the risk to the participants, right? And I think doing nothing is probably not a good thing to study because you're opening up staff to risk of harm, which, which review board is going to approve. So as far as education, what seems to be best is not totally online or remote learning and not totally all in-person learning. They find that people find it more palatable when it's a mixture of both. Knowing that a lot of these education programs have didactic, so classroom learning, here's what we want you to understand about violence, here's what we want you to understand about people, signs of escalation, how do you protect yourself, distancing and things of that nature. And then sometimes the second part of the class is how do you escape from certain situations? How do you do self-defense appropriately? What are some techniques that you can learn? But the other issue is, okay, so let's say you take your highest risk units, let's say the emergency department and behavioral health. You educate, they have to go through the intense education, like a full day, full 8-hour day of didactic and hands-on learning. But then what do you do for the rest of the staff, the rest of the units of the hospital? Some pretty hairy situations have happened in labor and delivery or in a neonatal ICU. Some very significant events and scary events can happen.
Or hospice, inpatient hospice.
Yeah, that too. So I think it's part of your plan should also include who needs it right now. You might need, as you start your program, who needs this now? Like when we started a program for one of my previous employers, we knew that security, behavioral health, and emergency departments are at highest risk. So they're going to go through the full class. And then the other units could go through like a half-day class. or they didn't necessarily need to learn the hands-on part of it. They could learn that didactic classroom part of it. So that's a strategy. Other things as far as education, what type of program are you going to do or how are you going to do it? Because that'll be different operationally. Are you going to have an instructor come in and teach all your classes? So you're going to bring somebody in, or are you going to do what's common is train the trainer? You have a master trainer that comes in and trains your staff. I went through 3 days of intense training and then I became an instructor. Then you have to have a pool of instructors to teach your classes if they're ongoing, if you have a fairly solid planned out program. But then what we also found in my experience is you're going to get a huge amount of attrition of your instructors. So in one program, we started with 30, we went up to 50. And by the time I left the organization, we were down to five active instructors. It's because their normal work, the work that they're hired for, takes precedence. And so we would see managers saying, no, I need you on the floor, or I need you on your unit, or just scheduling just doesn't work. So that's why we saw a bunch of attrition with that.
What are your thoughts around the zero tolerance approach? Because I've seen a couple of your posts on LinkedIn, and to be clear, a zero tolerance approach is the second priority from AONL and ENA as a guiding principle, essential elements of a zero tolerance framework.
Yeah.
What do you think about that?
As of late, I've been leaning against recommending zero tolerance in your language, in your policy language. You have to look at what does zero tolerance really mean? Zero tolerance, as it's defined, is there's a consequence for an infraction of a rule, and it is universally applied, no matter the circumstance. So, like due process goes out the window. And what the studies show is you might have zero tolerance policy. It might be worded in your policy that way, or we have zero tolerance for workplace violence. The studies have shown you actually tolerate a lot of violence. If you were truly zero tolerant, even the people who didn't know what they were doing was injuring somebody else would face a consequence in the spirit of zero tolerance. And when you do have zero tolerance, caregiver staff, sure, there might be an aggressive event, but you might know that this patient is in extremis or in a crisis and understand that, yet this violent episode happened, yet they're still here. I still have to take care of them. So they've called that the care paradox. It's like, I know we're not supposed to, but then we have to care for them on the other side before discharged. So they're here. It's going to happen. What's the consequence? Or I think there was a news article of a person being violent in the ED. They didn't get their medical screening exam, and then they go to die within a short amount of time. We have a duty to screen patients that come to us, especially in the emergency department, for an emergent condition, because there's many reasons why somebody can become violent. It's not just lack of self-regulation or coping mechanisms. There's plenty of medical reasons: tumors, electrolyte imbalances, infection. There's many reasons why somebody can display aggressive behavior. But for zero tolerance, I think it's good. It's meant well, but I don't think anybody, especially if you're using the word zero, can get to zero and truly have zero tolerance, because the data would show, from the injury data to the assault data, is like we are actually tolerating a lot of violence. And you could have the best program in the world as well, but then what happens on the back end, even if you like report it to law enforcement or the district attorney, they're technically the ones that can enforce a consequence, a significant consequence. And the other question is, what consequence do we do in healthcare for zero tolerance? So I think it's well-meaning, but I don't think it's practical in its actual implementation.
What are your thoughts around engaging the community and engaging the patients we serve in conversations around this issue? Because it seems like a lot of the conversations are happening among caregivers nowadays and not necessarily the people that we serve, that in many cases are those that are the aggressors.
Yeah, I think having a conversation with patients or even visitors is good. And I don't think it has been explored that much. But I'm thinking of one of our signs that we have up. Our healing environment is the title of it. And we're like, here's what's not acceptable. We ask to partner with you in providing a safe work environment for everybody, really. And that sign you could point to and be like, look, this is what we're asking of you. So that can be done on the hospital, even unit level, where the sign can be a primer for a conversation. You might have to have discussions of like, how do you talk about aggressive behavior? And it could be what we're finding out is really it has to be individualized to the patient. You think of care planning. So trying to understand why the person is the way they are and why they might be aggressive and what are their triggers? How do you know that they're escalating? And then what seems to work to de-escalate? I think that you might have to ask those questions if you don't know the patient very well or do a really deep dive on their chart. So I think that is one element of communicating and talking with patients. From what I've seen from the public policy side is a public awareness campaign might be helpful. I believe Maryland put that in their law last year. And what we're trying to do in Oregon is to mimic that. And the state would gather a committee. They would look at all the data and they will come up with recommendations of what a public awareness campaign could look like and what it should look like, even to the point of the state helping design like new signage that you could put up in your departments or in your hospitals. I think the public truly doesn't know how bad violence is in healthcare. Even our district attorneys don't know because if you're not regulated to report it anywhere, most people don't.
And what about lateral violence? It seems like we're starting to talk about that, but this is something that we're probably barely just scratching the surface on. It's not just the patients and their families that are creating workplace violent events. How do we get a handle on lateral violence?
That's a tough one. There's recommendations on how to address it. If you witness it, to be an active bystander, that is some of the things to help with lateral violence, to reporting up the chain. But we also know sometimes the chain of command is also can be part of the issue. There's not solid defined recommendations on that. And it's probably still remains to be a fairly large bugaboo. But it comes down to what are your expectations of behavior? And maybe that one department I worked in, they had a sign. It's like, I promised to do this and this and this, and everybody signed it. And that's can point to this bullet point number two is we've heard of an instance or I watched this where you're not complying with our agreed upon code of conduct. And I know it's hard. There's relationships that can suffer. We know I watched it happen where essentially the staff bullied a nurse out of the job and not fair. But I think when you see the behavior, it's important to speak up on it. I think documentation is also good. Going through the official channels up the chain of command is one way to help address it. And if you look at workplace violence, bullying can be in the definition. I think it's in the Joint Commission's definition now. Any type of bullying behavior is considered workplace violence. But I think we're at a loss. How do you tackle that? I think we're at a loss for what do you do? What do you do about it? Because you can take a lot of time and energy trying to get to the root of that problem. So I don't know of good, because I think one study that I looked at about the active bystander, here's our things you can say if you witness it, that they did some follow up. And yeah, the people who actually used it, they used it within the next month, but then you saw a drop off of people being active bystanders or active participants in addressing bullying behavior or calling out the snide comments or things of that nature. You saw it after education go up and then it fell. Like I'm sure it follows a similar curve of any type of education. You get quick compliance and people use what you have and then it slowly will die off.
What I hear you talking about, though, is it can't be a one and done approach. If we're going to deal with this issue, we really have to eat, live, and breathe a environment of inclusivity,
Yep.
an environment of addressing of events when they occur, an environment of not tolerating aggressive behavior, but I'm not using the words zero tolerance, and living it and breathing it on an ongoing basis.
Yeah. And what comes to my mind as we're talking is I think there's an opportunity for education for development of your own personal skills. Oftentimes people see it, but they're silent. They don't want to get caught up in it. They don't want to become the next target of the bully or the recipient of that bullying behavior. So they stay, I'm out of it. And maybe one thing that could be developed maybe is assertiveness skills. Because you think of just violence prevention in general, the skills that our caregivers learn from education or classes not only helps protect them at work, it helps protect them outside of work. So I think that's also important to understand because the basic concepts are the same. So I think going back to training of not only just being an active bystander, let's separate that from your own, like, how do I respond when I feel somebody's actually bullying me or, trying to clarify what they meant by their comment, or can I sit down with you and have a conversation? I've had to do that, and it was very uncomfortable. I was like, I feel that we are butting heads, and I'm just interested in your thoughts on that. Things like a simple conversation like that. But if you don't like conflicts, you probably will avoid the conversation.
Where do you see public policy's short gaps are, or where do you think we need to go in the public policy arena in the next 3 to 5 years?
Yeah, shortcomings in current public policy. From my personal experience here in Oregon, we've been trying to make an assault with injury on a healthcare worker a felony. It's currently just a misdemeanor right now. And our pushback has always been, what about those with mental illness? You're going to unfairly criminalize them. So last year was the furthest we ever got. And we actually had the conversations about it, but it was voted down. And this year, our plan is we're going to have a roundtable because from our perspective, and I'm the government affairs chair for Oregon Emergency Nurses Association, we are proposing legislation beyond felony legislation. And that includes mandatory reporting to the state for data collection and analysis, public awareness campaign, um, to how often do you require education? Is it every year? Is it every 2 years? Is it in person? Is it remote? There's a recommendation that it's every 2 years in person. After speaking with our hospital association and one of our representatives, we've gotten feedback on that to some small things of, anti-retaliation as well. There's some that exist in our law, but it could be, then I would say. So shortcomings there's disagreements, at least I know on a federal level, to mandate healthcare violence prevention programs for everybody. ENA supports that. We mostly support that. And I think eventually that will pass. I think we've gone through 2 or 3 legislative sessions with it on the books. For the past 2 legislative sessions, it's passed the House, but hasn't passed the Senate. So I think that'll come up again. I think that won't go away. I think that won't stop on federal legislation to create a standard, and that would be done by OSHA. So I think that will happen. I think more states will require a violence prevention program for healthcare or hospitals. For many years, it was only 9, and now we're up to 13 or 14. I like to brag about the West Coast because Washington State started it. Oregon followed in like 2007. And California followed in about 2012. So we have our programs pretty well established and can be looked to as models, really, of what state legislation can look like. And then you look at felony legislation. Montana's trying to make it a felony this year. Montana is one of 16 states that do not have this type of legislation. So that's interesting to know that more states than not have approved and found acceptable that if you assault a healthcare worker in their duties, there's an enhanced penalty of some sort. So that's interesting. I don't think that push will go away either, but at least for us here in Oregon, it's getting everybody to the table and ferreting out what's acceptable to everybody and what's palatable to everybody so that it can actually go forward in the legislation, be introduced, be supported bipartisanly and pass and become law.
Great. So we talked about the 3 things that a nurse leader needs to know. Having a plan, I think, is what you mentioned to mitigate the effects both before and after, supporting the caregiver after a workplace violent incident occurs, and then understanding or considering that the violence prevention as a program requires really active management. Are there
Correct.
any other closing thoughts that you have as we wrap up this episode?
Yeah, maybe one is I would recommend that hospitals either develop or create the position of a violence prevention program manager. With the increasing regulations, such as the Joint Commission, and there's been proposed federal legislation on creating violence prevention programs in healthcare, there's enough work to employ somebody full time to look at your violence prevention program. That goes from looking at policy to the education to the various initiatives like flagging, or do you want to bring in metal detectors? Do you want to bring in canines? Looking at the data on a daily, weekly, monthly basis, making sure the reporting is all correct. Because currently, I think the current kind of way we do it is we ask everybody to do this on top of their regular jobs. And your work waxes and wanes. So you might not be able to make the meeting or participate in the subgroup that's looking at risk for violence flagging in patient charts and the process for that, and even auditing. Okay, so let's say we did put risk for violence flags. How do you audit those to make sure that they are appropriate? So I think we've seen the violence prevention program manager position rise here, at least in the Pacific Northwest. There's quite a few of us in the Portland area that already have this program manager position, but I think it's fairly new. But I think we're to the point, like if you're going to have a STEMI coordinator or a STEMI program manager or a stroke program manager that really keeps an eye and does continuous quality improvement, there's enough work for violence prevention as well.
Bill, thank you so much. I appreciate you taking the time, your busy time today, to talk with us all things workplace violence prevention strategies, and appreciate all your continued endeavors, not just at your employer, but across the country to improve things so that we all can be working in a health and safety working environment.
Thanks for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.